So I'd like to give a special thank you to our moderator, Mr. Calvin Martin. He is the deacon of Convent Avenue Baptist Church. He's a past Grand Master to the Prince Hall Masons of New York State and founder of Brother to Brother, a prostate cancer support group. Calvin, take it. It's all yours.
Thank you, Ms. Reyes, for those very kind and complimentary words of introduction. We're now looking at a picture that depicts the community outreach engagement team. And this is a team that does a lot of work in the Harlem community, trying to narrow the health disparities. They consist of 5 staff members and about 15 members of the advisory board. And I'd just like to thank you so much for all the work that you do in our community.
Thank you, Calvin.
Well, we have a couple of sponsors that I would like to give, let them know how much we appreciate them. We have the Prince Hall Medical Foundation, which is located at 454 West 155th Street, New York City. And the director is a guy by the name of Right Worshipful Gregory R. Smith Jr. The leader of that organization is Right Worshipful Walter C. King Jr. We also have the Convent Avenue Baptist Church, which I am a member of. They're located at 420 West 145th Street in New York City, and it's pastored by the Reverend Dr. Jesse T. Williams Jr. And we have a third sponsor, the Hispanic Federation. Thank you so much for all that you do. We have 2 speakers tonight. The first speaker will be a brother that I know very well. He's a prostate cancer survivor. And as I was speaking to him earlier, he went through treatment around this time last year. He is Randell Burch, who grew up in Brooklyn, New York, attended Xavier High School and received a basketball scholarship for Long Island University, the Brooklyn campus. Brother Burch worked as a system programmer for 25 years in the field of publishing, banking, healthcare, and insurance prior to starting a residential cleaning company. He is now the owner of a real estate management and home remodeling company in New Jersey. Brother Burch presently is a member of the following community engagement and service organizations: New York Prince Hall Masons, the Board of Education of Somerset County Vocational High School, Somerset County Black Caucus, and Somerset County Hispanic Caucus. Brother Burch, you're on.
Good afternoon, everyone. Good evening. As Calvin has clearly stated, around last year, this time, I was going through this process. And I'm going to just kind of take you through my experience real quickly. July 15th of last year, I was having an extremely difficult time breathing. So, I asked my wife, I said, I think it's, especially with COVID, I said, I think this is an opportunity, a time for me to go, to the emergency room to find out what's going on. After getting a COVID test and that coming back negative, and they were taking a look at my x-ray, they realized that I had a huge pulmonary embolism. I did not know at the time, but it was so great that my life was really in danger at that time. And because my COVID test came back negative, they were trying to ascertain why, because it's one of the signs of COVID is having, respiratory issues. Not being able to find any reason for it, I was given a full body scan. The scan revealed that my prostate was enlarged. Now, I had been under the care of a urologist for many years, and my last appointment was in December of 2019. So I knew that at that time, there really had not been any change. So I asked the medical staff to contact my doctor, who was a member of the hospital, and I informed them that I had a history of an enlarged prostate, and to check between my last appointment and that one to ascertain whether or not there was a difference. Coming back, there was a difference. My doctor decided to wait for me to be discharged so that he can give me antibiotics. He says sometimes if you have a virus of some type, it can, enlarge your prostate. Took the 2 weeks of antibiotics, did not change after the next PSA. Then we went in for the biopsy. Biopsy came back positive. And at that time, he said the next step was for me to make a decision on my treatment. Of course, I'm not sure, for those who are listening for the first time, there's several methods of treatment. Radiation, there's two types, cyberknife, which is a more accurate way of getting those rays to the prostate and limiting the exposure to other organs and things that may be in the vicinity, regular radiation, and of course, having the prostate removed. The very first thing I did was get on the phone and I called people who I knew had had a similar experience. And I was very fortunate. It's probably something that a lot of men may not want to readily discuss, but I was very fortunate in that there were a lot of people in our fraternity, Prince Hall Masons, and personally who was more than happy to share their experience, and Calvin being one of them, was very helpful in my research. After hearing what my options were and listening to some of the stories, I made the decision to have mine removed. And I made that decision because of some of the stories that I've heard. And the most important thing for me, and I have to say this, and I think it's very important, because when you start talking about the prostate with men, the very first thing they start thinking about is sexual activity. So for those of us who may have our, I'll use this term loosely, manhood focused, on our performance and relationships, this could be a very difficult decision. For me, it wasn't. The most important thing for me was to survive this. And the message that I received from everyone I talked to was just that. It was something, if caught early, you can survive. So I elected to have mine removed because at least 5 of the individuals I spoke with, it was clear to me that having a surgeon actually being able to look at the environment of the prostate and the surrounding areas brought me comfort, because one thing I did not want to do, having selected, in my opinion, one of the other options, was I was concerned about my quality of life. I didn't want to have the, I didn't want to be weighed down wondering if the prostate cancer had gotten outside of the prostate, infected other areas, and then, be concerned about it coming back. So I felt that if I had a surgeon to be able to take a look, see exactly what was going on, see whether or not it came out, we would know right away what action to take, if any. And if everything was fine, then moving forward in my life, I would have a better quality, because that would be one of the things that I can really put in, the back burner. Of course, understanding that there are going to be follow-up appointments and checkups over the years. So I also did something that I think I may have been the only person who had done this prior to. When I made my decision, I decided to have it done, and it's done robotically. I actually went on YouTube and I watched a couple of surgeries to see exactly how long it was going to take, and what type of benefits I would get from that procedure. I was very fortunate that my urologist only recommended 2 surgeons to me. Both surgeons were chief of surgeons in their institutions. One was Memorial Sloan Kettering in New York, and the other one was Rutgers University Cancer Center here in New Jersey. And I chose the one closest to me for 2 reasons. Number one, having my family close, and it's literally only a few minutes from my home. And the other was, going back and forth to New York. I didn't want to put that type of strain on my wife in the event that it required me to go back a little bit more often than, scheduled. The surgery went well. I can honestly tell you, being an athlete, I've had many surgeries. My last surgery was a rotator cuff. It was I would have the surgery again tomorrow. I can honestly tell you, it was one of the most pleasant experiences I've ever had. There's also many, depending on weight and size and other, diameters. I was very fortunate to only have one incision that I could not probably, you would not know unless I pointed it out to you, like near my navel, where the prostate was taken out. And the recovery was also something that I thought was going to be, extremely painful and difficult to work through. And that was not, a problem for myself either. So I guess this November 2nd would be a year that I've had the surgery. I'm back to work doing everything that I was able to do before. As far as, sexual activity is concerned, that's not that bad. I thought it was going to be a lot worse than described. Moving forward, I don't see any problems at all. I strongly recommend that all men, whether you fall into the category or not, there are definitely things that we can do to bring the odds down of us having to have our prostate removed or having problems with it. And like anything else, education and discussion are the key.
Thank you, Brother Burch, for that very timely and informative rendition of what you went through and the outcome Next, we will have Dr. Joseph Alukal. Dr. Joseph Alukal is Director of Men's Health at Columbia University Irving Medical Center and Associate Professor in the Department of Urology of the Columbia University of Val Goes College of Physician and Surgeon. He is a national and international expert in the fields of male infertility, male sexual dysfunction, and men's health. He received his medical degree in 2002 from the University of North Carolina at Chapel Hill School of Medicine. Dr. Alukal is past president of the Society of the Study for Male Reproduction. He has served with both the American Urological Association and the American Society of Reproductive Medicine in numerous leadership capacities. I've had the good fortune of working with him on a couple of occasions, and he is a man about the community and someone that is worth listening to. Dr. Alukal.
Calvin, thank you so much. I appreciate the kind introduction, and I appreciate the opportunity to talk tonight. And I'd like to say thank you to Brother Burch first of all, and most importantly, for sharing your experience with us. I know how difficult that can be, and I think it helps so much for people to have the chance to hear somebody who's come through this and is doing fine on the other side. I think everybody needs to know that, because it helps to put some of their own fears to allay them. So thank you. And I want to start by talking just a little bit about prostate cancer to help get people up to speed. It's important for us to talk about this disease, think about it, come up with better treatment options, because it is the most common solid tumor that occurs in men. As Brother Burch alluded to, our treatment options, thinking broadly, include radiation or surgery, although there are other things that we do for people with certain kinds of prostate cancer in terms of hormone treatments, chemotherapy for some people. Let me see if I can't get that to go backwards now. Okay. Andrea, can you back up one slide? Thank you. Thinking about surgery and radiation, as Brother Burch alluded to, men are worried about the idea that getting treated for prostate cancer is going to, as he said, interfere with their manhood. And both these treatments that we're talking about can cause erectile dysfunction. And honestly, the hormone treatments can as well. And so it is something that it's understandable why men are concerned about this. And again, when we talk about the idea that this is a common disease, it's not just the people who we know about who have the disease. We think that right now in the United States, there's 2 million men either with prostate cancer or who have survived prostate cancer. But obviously some of those men with prostate cancer, they don't know about it. And so that's an important thing for us to keep in mind. It's not, you know, a rare disease at all. It's very, very common. Let me see if, there we go. So things I want to make sure that we address as we're talking about this, you know, over these next few minutes. These are all things I've heard patients say to me, okay? One, nobody needs to have a prostate exam anymore. No one wants to have a finger back there, but nobody needs to have it, doctor, because a blood test alone is good enough. Doctor, I don't know why anybody's looking into this for me anyway, because last I checked, nobody dies from prostate cancer anymore. Why are we worried about this? Doctor, I don't want a biopsy because I'm worried that the cancer I might have could spread if somebody puts a needle in there. And then last, and we've already addressed it, if I have to get treatment for prostate cancer, I won't be a man anymore. And so these are all myths. They're not true, but I want to make sure we understand, you know, what is the actual truth here, and that we leave this talk with a better understanding of that. So when we go forward, we're not confused either when our family or our friends ask us about this or when we're thinking about it ourselves. What is the prostate? You know, we've got all kinds of organs in our body that can get cancer. Our skin can get cancer, our lung can get cancer, our liver can get cancer. Well, our prostate can get cancer. Well, what does the prostate do? It's a very good question. It's found in almost all mammals, and it has something to do with reproductive function in almost all mammals. It comes from a very particular part of the developing embryo, and its only real function in a man, other than to cause us trouble as we get older, I hate to say it, its only actual function is to make some portion of the fluid that goes into semen and then to actually enable that to be ejaculated. So it's very important from a reproduction standpoint. And the other issues it can cause in men, in addition to prostate cancer, are urinary complaints. So men will tell you, you know, doctors, I've gotten older, I wake up at night to go pee more often, or sometimes I find myself, I gotta get up, run out of a meeting, go to the bathroom, and I don't pee the way I used to. If I'm at the ball game, I'm standing there in front of the urinal for 5 minutes and 3 people right next to me have come and gone on both sides of me. What's going on? I go, it's probably your prostate, and we have to figure out what to do about it. That's before you get to things like prostate infections, which can make people very sick, or pain in the prostate, which happens to lots of men. So it really can be a troublesome organ for people to have to deal with. And many, many times, if they're having a problem with their prostate, they're coming to see a doctor like myself. They're coming to see a urologist. To give people some sense as to where the thing is, it's next door neighbors with your bladder. So this is a cross section of a man's pelvis, and you can see here the colon and the rectum, which store feces. You can see here the bladder, which stores urine, and the prostate right here at the front door of the bladder. And so here we have this sense of a tumor of the prostate growing within that tissue. But you could also imagine, as well, as the prostate enlarges, even if it doesn't have cancer, it can certainly make it harder for the patient to be able to pee the way they did when they were, 15, 20 years old. An important detail, this is why people have to go through that finger exam. Somebody can put their finger in the rectum and feel a surface of the prostate for abnormalities, for a change, both in terms of suspicious lesions that may make you think of cancer or in terms of enlargement. And it is something that, unfortunately, PSA testing, the blood test that we've talked about a little bit already, that we use to screen for prostate cancer, it does miss some rare aggressive cancers. I tell the medical students, we still put our finger back there because occasionally you'll feel something that feels like a piece of gravel. And you have to tell that patient, hey, we've got to move on this pretty quickly. And sometimes that patient unexpectedly has a low PSA. So unfortunately, we're not yet at a point where we get to do away with this exam. I know people don't like it. I'm always talking to them about, hey, I don't think we need to do this more than once a year, only during certain ages. I probably don't have to do it to a 25-year-old man. And then as well, there are other doctors who do that exam also, like a gastroenterologist. So if that doctor saw you recently and put their finger back there, or your internist did, I don't have to do it to you again. I'm always trying to spare people kind of the embarrassment and the discomfort of going through this. But I remind people it's just a few uncomfortable moments, but it gets you a year's worth of peace of mind. We ought to just do it. Let's get it over and done with. This is another anatomic representation. Again, a cross section. Here again is the bladder. Here again is the prostate, and this is the rectum. And here we're actually demonstrating a biopsy of the prostate. Okay, so you have an ultrasound probe in the same place where somebody would put their finger, and then this needle is being passed through the wall of the rectum and into the prostate to sample the tissue in there. And so this is, as it currently stands, the only way we have to diagnose prostate cancer. You can actually do this biopsy through the skin on the surface of what's called the perineum. Maybe there's a slightly lower risk of infection with that. But there's no way to diagnose cancer without doing a biopsy. And I remind the people who ask me, hey, isn't a biopsy going to cause my cancer to spread? I remind people, no, that's not the case. If that were the case, seeing as this is the only way we have to diagnose prostate cancer, no one would ever be cured. If we always spread the cancer by putting that needle in there, no one would ever have an opportunity to cure. So we know that not to be a concern that people have to have. This is one of the tools we have these days to help us with diagnosing men who have prostate cancer, which is MRI of the prostate. And here we have a cross section of the pelvis, but in a different direction. Before, you could imagine we were moving up and down. Now imagine the magician doing his trick and sawing somebody in half. And here are the bones of the pelvis up here and the muscles of the abdomen, the patient's belly up here. And here we're looking through the prostate as if somebody had cut a piece of fruit in half. And it's to give you a sense again of how big or small this organ is. Now it can vary in size depending upon the patient, their age. A young man, their prostate might be the size of a big cherry, a walnut. Men, as we age and the prostate grows, you can sometimes come across a man with the prostate the size of a lemon or an orange or even a grapefruit. And so we have to have a sense of the size of the patient's prostate as we're weighing what options are available for them in terms of treatment if we've figured out that they have a prostate cancer. So as I alluded to, other things that can happen in the prostate, they tend to be more common than prostate cancer. The urinary symptoms that are associated with the prostate just getting bigger, that could be almost 500,000 visits to the doctor every year in the US. Inflammation or infection in the prostate, also a very common problem. Prostate cancer, now we're talking about a couple 100,000 cases of new prostate cancer every year in the United States. So a man who gets diagnosed by a urologist like myself, as the year goes on, at the beginning of the year, he didn't know that he had cancer. That's 200,000 men over the course of the year on average. The confusing thing is all three of these conditions can cause PSA, that blood test, to go up. So how do we figure out who is whom? Who has cancer, who has an infection, who just has an enlarged prostate? And what else do we know about this test? This test has been around, helping us with this diagnosis for really about 40 years. It was described in the 1980s and started being used much more commonly by the late 80s. And what we're really talking about is a substance that's made only by the prostate. Okay, so if there's a lot of it in the bloodstream, that means that something's going on in the prostate that's enabling this substance to get out of the prostate cells and into the bloodstream. And usually with prostate cancer, that means that you have cells that are being born, they're living, and they're dying. Okay, and when they die, they release this substance into the bloodstream. But there are other processes in the prostate that can cause the same thing. Again, an infection is very good at this. If you made a mistake and checked the patient's PSA the day after he had a biopsy, I'm never surprised to see that number go way up. So I want patients to remember that one high PSA measurement does not automatically mean that they have prostate cancer. We used to talk about the idea that a PSA above 4 was too high and below 4 was fine. But over those 40 years of watching lots of men come in with abnormal PSAs, and we figured out who did or didn't have prostate cancer, we started to realize that those numbers really make a lot more sense if you think about the patient's age as well. So patient who's in his late 40s and has a PSA of 3.8, I got to actually tell him something very different than a patient in his late 70s with a PSA of 3.8. The second gentleman, the older gentleman, is probably at a much lower risk of prostate cancer. The first gentleman, we really should be looking for it. And by doing things like adjusting for the patient's age, we've helped ourselves in terms of being able to better identify cancers that are important for the patient to find out about, potentially dangerous cancers, for example, in younger men. We have some other concepts that help us to figure out whose PSA elevation is more likely to speak to a prostate cancer risk. The patient whose PSA is going up very rapidly, 1 year it's 2, the next year it's 4, as opposed to 1 year it's 2 and the next year it's 2.4. Or the patient and their free PSA, a very specific test that looks at a certain kind of PSA, more likely to be elevated in the patient with cancer. So to go back to these myths, the blood test isn't good enough. It doesn't distinguish between benign conditions like enlargement or a prostate infection. And again, it's still missing some of those people with aggressive prostate cancers, unfortunately. No one dies from prostate cancer. We've made a lot of progress in terms of keeping men alive with prostate cancer, but it's still something like 20,000 men every year in the United States who will die of prostate cancer. In the 1980s, when we first started using PSA, that number was about 40,000 men. So we've managed to cut that in half, but there are still people who are dying of this disease, obviously of more aggressive prostate cancers. I talked about the idea that a biopsy is not going to cause a prostate cancer to spread. And then lastly, most importantly, the idea that any of these treatments, yes, they carry a risk of causing problems with sexual function, but yes, those problems are solvable, and no, it's not a guarantee that somebody's going to have those problems. So I do want to make sure that patients understand, hey, I may not necessarily end up with those issues, and if I do, those are solvable issues. But treating my cancer, if my doctor thinks that's appropriate, and if my family is ready to move forward with me on this, that's what's going to keep me here and alive and in the game. I can figure out what I can do after the fact to solve these kinds of problems if I end up with them. So I believe that's it. I want to open the floor to any questions people might have, and certainly they can feel free to put them into the chat as well. And thanks again for the opportunity.
Before the questions, I'd like to thank both speakers for the sharing with us this afternoon. They certainly give us a better understanding of the prostate cancer. And Dr. Alukal, we thank you so much for this dispelling some of the myths that surround prostate and prostate cancer. So thank both of you very much.